So welcome, welcome, welcome. I'm Mike Kirchhoff. I'm the Chief Innovation Officer here at Cooper University Healthcare. Thank you for coming this evening. I really appreciate you taking time out of your day to come and hear these groundbreaking ideas that our esteemed panelists and our video today will show you the state of where we're moving with neuromodulation and mindfulness in healthcare and in the nation. So a little bit about the Cooper Health System and, more importantly, the Cooper Innovation Center. Our mandate is to commercialize inventions from Cooper. The other is to teach entrepreneurship. And probably, to me, the thing that's most important is to be a clinical partner to new-to-market technologies and therapies. And one of the things that really brings me joy is talking to these great leaders in the therapeutic space, bringing these fantastic new therapies. And I say new because they're newly accepted, but they've been around for millennia, 3,000 years by some measurements. These substances have helped societies grow in very unique ways, and we're learning today can help many, many people suffering from many, many neurocognitive issues. Major depression, PTSD, addiction, and we're really just scratching the surface today. And really, the clinical partnerships is one of really the way that we're bringing great forward-thinking folks to Cooper. So I just want to talk a little bit about the frame I'm going to ask you for today. So this is a little DALL-E, ChatGPT, OpenAI thing that my prompt here was ancient wisdom meets modern medicine. And that was the only prompt. And as you could see already, the mushroom. But what I want to point out here is the balance of ancient wisdom, wisdom of the community, wisdom of the masses. There's something to be said for what communities and civilizations have been doing for millennia that we, in science, should pay attention to and learn from. And we need to balance that with rigorous review, rigorous study, to really understand how we can best bring these therapies to bear on patients and to communities so they can heal. So I was very excited about this picture. I mean, you know, DALL-E got it right, I think. It's a balance, and clearly those natural substances that societies have been using for millennia really is something we should have been paying attention to quite some time ago. And that's the other thing I want you to bring to our conversation today is why were we not paying attention to these substances years ago? Maybe it has something to do with your upbringing. Maybe it has something to do with laws. Maybe it has something to do with your society. But everybody brings an experience to how they approach healing, how they approach healthcare, how they approach whatever it is that you're approaching. So I want you to think about when you're seeing the film today and when you're listening to the reactor panel, to really think about how do you feel about this? If you're here, I suspect you're behind this, right? But there are many people out in the community that are not behind these ideas. So the idea of the film and the reactor panel today is to bring those opinions out here in the light so we can have a conversation about how to bring these much needed modalities to the communities that need them most. So I want you to think about your frame and your journey here today and how it's influenced your opinion about what we're going to be talking about today, because ultimately what we want to do is we have the innovators here and some early adopters, but this diffusion of technology, this fusion of acceptance of these modalities needs to accelerate. And where are we on that acceleration curve, that adoption curve? I don't know yet. Clearly low down, but are we about to take off? Maybe. We have groups here today, some of our sponsors, sponsoring bills in the Senate and helping support and write that legislation to get the studies that need to get done so we can show the science to really bring these important treatments to the groups that need them the most. Veterans, those suffering with major depression, addiction, etc. And Cooper is well suited for that. We have a long history of working with the VA, long history of working with addiction, long history of working with underserved communities, and those communities need these treatments. So we're going to bring the science and those supporting their adoption to here so we can have a conversation about how to make that happen. So what I'm going to do is going to call up Neil and Riley. Neil Lemon, PhD, MPH, MBA, not MPH.
That's right.
Our director of our Innovation Center, Riley Cote, former NHL player. And really, the frame I want to give you for their conversation is the frames they bring. Neil brings an experience of commercialization and technology transfer, and Riley brings his life story. To be an advocate for patients, you often have to be a patient yourself. To be an advocate for others, you often have to advocate for yourself first. And I really want you to take to heart the journey of both of these men, but especially Riley, because while your story is very compelling and some of it must have been hard for you, if it wasn't for those trials, you wouldn't be here today. And you wouldn't be helping us bring these important, vital treatments to patients that need them most. So we thank you for your experience, and we thank you for bringing it to us today. So without further ado, Neil and Riley.
All right. Good. Thank you. Thank you. Yeah, first off, thanks, Riley, for agreeing to to discuss with us at this forum and share your story through the documentary. I think it's really, really engaging. My background is in neurophysiology. I've seen some of the stigma attached to plant-based medicines and the treatment, but also recently all the good that they can do, and to have early adopters come in and share their story and kind of push the boundaries as far as getting the sort of research that's done to have a broader acceptance of these therapies is very, very important. So in introduction to the documentary, I'd like to ask you a little bit about your story, your history, experience with where you came to the place, where you felt you needed treatment, and your experience with traditional medicine, and how did that work, or maybe it was not working for you, and how that got you down a path of discovery that is illuminated in the documentary.
Yeah, so it's a pretty interesting journey I've been on, and I think it was end of 2009, 2010 hockey season where I saw my hockey career come to a crossroads of deciding if I could continue on the way I was going and or accepting the honest truth of me having to move on and face the hard truth of that was the end of my my childhood dream. And I'd been dealing with some concussion-related issues and some substance abuse issues, and at the end of the season, we lost the Chicago Blackhawks in 2010 and had a nice run. And I was faced with two different surgeries, one on my finger and one on my nose, and it was a time where I made the choice to use plant medicine for the pain management piece. So I used cannabis my last two surgeries and avoided taking the prescription drugs because I had seen the darkness around the prescription drugs, specifically opioid-based drugs, as well as alcohol. But so I made the decision based on experience. I had a relationship with cannabis, but a very misunderstood one. And but it gave me enough faith in kind of following my heart with the cannabis. So those last two surgeries, just used cannabis, and I read a book called Hemp for Health that kind of helped me make sense of the cannabis plant in its entirety, the industrial applications of the plant, as well as some of these different compounds. As most people had just been introduced to THC, well, I started to understand there were several other cannabinoids that were very helpful for pain, but also for the brain. And that led me down another rabbit hole around psilocybin mushrooms, where I had some version of a recreational relationship with, but enough experience with it to understand that there was something there. Yeah. So using cannabis for pain, cannabis, different versions of cannabis, CBD for the brain, and then the next phase was really kind of attacking the brain issue and the substance abuse issue with psilocybin mushrooms. So it's been an interesting journey, and it was one thing I avoided was getting a diagnosis because I just saw what was happening to some of the guys I'd played with. just getting dragged down all these different rabbit holes, all these different opinions, and they had a hard time getting themselves out of that. So, you know, some people would, you know, disagree with my choice on that because it might not have gone as well for some people, and I'm just grateful that it went the right way for me. But it also gave me the freedom to either succeed or fail with this, right? And I just kind of followed my heart based on experience, and I'm grateful that I did because it's really been extremely helpful.
No, I think we're very fortunate that you did go down that path and you were able to share your story and advocate for a different way at looking at maybe a more holistic way of treating some of the underlying conditions. And we definitely here at Cooper, and you'll hear from some of the providers that we have on the panel, have been looking at integrating approaches to pain treatment, addiction, and mental health. And it seems like it started more or less with pain. You had some surgeries and maybe an instinct that the treatments being offered, and from learning from your colleagues, right, in professional sports, that the outcomes weren't good with the existing treatments. And you know, it's good that traditional medicine kind of learns from that and listens to their patients. And then you took an interesting pathway kind of going outside traditional medicine to explore alternatives. And maybe it started with kind of marijuana, CBD, because you had a relationship with that and you could understand how it would treat your pain. But maybe as you moved on and we're looking at psychedelics also as a treatment, you know, associated with pain, you know, substance use, you know, mental issues. Psychedelics often used for treating depression, other things, TBI, you know, concussion. Where did that journey begin? That kind of the move from having an understanding of CBD and marijuana to like, okay, these psychedelics could also be helpful. And the underlying theme here is these are plant-based medicines, right? Dr. Kirchhoff mentioned they've been used for thousands of years. They also fall outside of the traditional patented pharmaceutical pathway to treating patients, right? So there's a difficulty raising the sort of funds that are needed to support clinical studies, which, you know, traditional medicine requires in order to prescribe and get refunded and all of this. But you found an alternative pathway around that. So where was the connection where, I know you live in Westchester, you know, which is out by the mushroom capital of the world.
Well, I'm actually in New York, Delaware, but still close to Kennett Square and the whole bit. Nutritional mushrooms, a little different species. But it was not too long after I retired. Honestly, the two surgeries, I proved to myself that I could, you know, treat my pain issues with cannabis versus taking an opioid-based drug, which was a pretty big breakthrough. It wasn't too long thereafter, I decided to retire, another year on my contract, but decided to retire, and that's when I really started engaging in treating the brain. Again, I was dealing with some concussion-related issues. I was, you know, fogged out that last year. I was kind of, again, in an interesting situation in my career. I wasn't playing a whole lot. You know, I had my bell rung several times. I was drinking more than I should have, and so there's a mixture of like all these different things that I couldn't, you know, make sense of, like where it was all coming from. Obviously, accumulation of it all, but so shortly thereafter is when I really started to explore the use of psilocybin it was really targeted for the brain. I didn't really understand the rest of it, you know, that I kind of had a few aha moments after the fact of like, I kind of get this now. But, you know, beyond how it helped my brain health and just my focus and clarity and just the way I was thinking, perspective, I think it also really helped with transitioning from a very egocentric job and role that I was playing, not just a hockey player, as a fighter. And it helped me transition and really kind of shed my old skin and kind of find new purpose. So there was this element of like almost like speaking for the trees now, like, oh, wow, like this is helping me, and I almost like want to scream at the top of the rooftops and like, you know what I mean, like share this with people, share my experiences. So you know, that led me down having understanding of meditation and yoga, which I, you know, approached yoga as just as physical exercise and started understanding the spiritual nature of what yoga was and meditation. So it really kind of helped me get onto my mat and understand why I was standing on my mat in the first place, and really kind of really dove deep into this path of meditation, understanding the spiritual nature of what these medicines are really providing us.
So do you think without the addition of the assistance of the psilocybin, you would have been able to make that mental shift and to take advantage of the other opportunities, that were put in front of you for, self-health, renewal, the yoga, the meditation, the perspective shift that occurred? Is it part of integrated in that journey, the psilocybin and the shift in perspective in how to live your life differently?
100%, yeah. I'm not going to say I couldn't have found those healing modalities without psilocybin, but it was an amazing catalyst to bring perspective on my thinking, my behavior, and just the way I was engaging in the world. So it's a real major shift of consciousness, awareness, right? So then all of a sudden you sit back and you look at, the life you're living, and you're like, well, I got to make some significant change. So it kind of, brings an amazing awareness around, again, your thinking, starting with thought, right? And how you're thinking, and where you're putting your energy and your focus. And again, that being said, I know you can find healing without it, but I think it was certainly an amazing catalyst to jumpstart and put things in perspective and get me going sooner than it probably had been without it.
Yeah, and I definitely think, and I know from the providers we'll talk with after the documentary, that being open to kind of natural medicines, different approaches to healing is important, as opposed to just relying on prescription drugs. Even in my own family, before my mom passed away, she had the opioids, but in addition to that, she took like CBD gummies, and it helped a great amount. Like the opioids helped to a point, but there's so many applications for some of these substances in certain contexts that we need to be open to that. I'm very proud of it. The folks at Cooper that I work with are open to that and wanting to provide some of the evidence that can help with wider adoption. And early adopters like you helping spread the message is very, very important to, to getting the support needed to branch this out, as Dr. Kirchhoff mentioned, and to help a lot of people.
Yeah. I think the most exciting thing for me in this whole movement is it's really challenging the medical model. It's really kind of bridging the gap between medical and spiritual, because there's no denying the spiritual nature of these medicines and really what it's trying to teach us. Again, I mentioned like the yoga and the meditation, but simple things like breath, right? Like breath is spirit and like life force, right? And like all these things that are within us that we can tap into anytime, anywhere. But until you're like aware of them, even though they seem pretty simple and fundamental, we don't tap into them. They're almost just, they're kind of just there. But I think really the psychedelic movement is certainly gonna, I'm not gonna say challenge, but it's definitely gonna be merging with the medical system, because I feel like it's almost like the spiritual nature of healing has been abandoned almost, and I think this is an amazing time to be alive, honestly, because God knows we need something better than what's currently out there for depression, anxiety, PTSD, all the above, really.
And your advocacy is really helping kind of brush off some of the old prejudices that go back decades, which have kind of gotten in the way of exploring some of these treatments. And
right.
Kind of, we're also looking at other business models. You're an entrepreneur in this space as well. Trying to promote the use of, psychedelics, natural medicines. We very much appreciate that and the work you've done with Cooper to promote that work as well.
Yeah, thank you. No, happy to. I feel like it's my duty, once you make sense of these types of medicines and how they can really help shift the course of healing and medicine, you can't help yourself but wanting to be vulnerable and speak and speak for these sacred plant medicines. So happy to do my part and just be a ripple really in this movement. So
excellent. So I think maybe we'll start with the documentary, if the AV people in the back can hear me, and then we'll follow that up with a panel discussion immediately afterwards. And everybody that stays around, we have a reception with lots of food and drink. So it's not over when the talking on the stage stops. So we want everybody to congregate and discuss what occurred today.
Beautiful. Thank you.
Thanks.
Just want to take a minute to express gratitude for those that were kind enough and brave enough in that documentary to share their story. My kids go to a Quaker school, so I'm just going to ask us to take a moment to center ourselves and think about what we just experienced and focus on our own connection to those stories we heard. Now, it's no accident that ESPN did this documentary. It's no accident that athletes are using their celebrity to promote this. And I want to thank the athletes. And I want to call out a couple folks in this room and some of our sponsors about why this is important. So a group, Enable Health, connected us with Athletes for Care. And really, it's an organization that brings these stories to the fore, right? We learn, we experience through ourselves or the story of others. And if we can't share those stories, we can't move forward. And we're very grateful for these stories and Athletes for Care and Enable Health for connecting us with the great work they're doing. It's so important to leverage their standing in society to move things forward, and we thank them for that. A couple other groups that I want to call out, Anthea really working with payers to help us understand how, with the VA, we can bring these important therapies to our veterans. New Jersey Health Foundation, really in the fore in the New Jersey market and actually nationally of financing innovation and the work we're not only doing here at Cooper, but throughout the state of New Jersey and throughout the U.S. To really start that early development in these innovative ideas. And then, of course, the SPORE group and Reasons for Hope around setting up clinics and bringing these ideas to the people that need them the most. And then, of course, Wake, because, they brought us Riley and the work that he's doing. And really, as you can see, also starting to do that important research that was cut so abruptly short in the mid-century. So we thank you all for everything you've done. We thank our sponsors, and we thank, most importantly, those that shared and opened up their story to us today. So thank you. So in the spirit of exploring this further, Dr. Lemon will be now running a panel to help us sort of talk about this more broadly. And I really want people to think about how you responded to this documentary to inform your questions, because we very much want this to be a discussion, a dialogue, so that we can all learn and grow from this experience. So, Dr. Lemon, I'll turn it over to you to introduce the panel.
Excellent. I might just invite all the panelists up to the seats. We'll move the chairs, move the furniture around a little bit. And then I'll introduce each of you to begin with. And we'll go through roughly 10 minutes or so a piece, going through some of your stories to share, and then we'll open things up for questions. So in total, maybe 40, 45 minutes, and we'll culminate with questions and a discussion from the audience for 15 minutes, and we'll break for sustenance and discussion, right? Okay. So, quick introduction. Dr. Michael Sabia is our head of the Division for Pain at Cooper. Fantastic physician. We've been working with him at the Innovation Center since I started a year ago, and our Chief Innovation Officer, Dr. Kirchhoff, knows him for a lot longer than that. He's been very open to working with the other principals at Cooper, also in the addiction space, mental health space, and we have some exciting things we're working on together there. I've been a proponent of alternatives to opioid use and responsible opioid use, and we'll get into that discussion. Katie Walker from Revitalists, CEO for that company, successfully runs some ketamine clinics and has a relationship with the VA, negotiated a veteran cares agreement, doing a lot of good in that space, looking at alternative treatments. We're working with them to see how we can also expand some of our service delivery at Cooper in the space. Dr. Basant Pradhan, very, very interesting man, has a background both as a monk and as a trained psychiatrist. He's the head of a fellowship that we have exploring alternative paths to neuromodulation, and really has a focus on a holistic approach to healthcare delivery. And fantastic, kind of one of several leaders that we're looking at to integrate further Cooper services. And Jessica Tracy, who has a very unique skill set, coming with a background as an executive in the insurance industry, also as an executive with a healthcare company, in addition to being a patient advocate and having a leadership role with the ketamine task force. So really bringing the payer perspective, the business perspective, and the patient advocacy perspective to this topic, and somebody that we're very happy to be working with at Cooper. So I'll start with kind of discussions, a discussion with Dr. Sabia, and hopefully at the end everybody can integrate in, and if the other panelists have something they want to add, I think all the mics are live, so are they? Or maybe there's they'll flip them all on, I guess. So, Dr. Sabia, given your experience in pain treatment and head of the pain division at Cooper, you've been experienced through the opioid epidemic, treatments, changes in treatments. Maybe if you could speak to me or speak to the crowd a little bit about your experience with opioids, their use, alternatives that you have come across, and how your practice and those of your colleagues has maybe changed over time.
Absolutely. Thanks, Neil. So I think the best way to approach this is to discuss a clinical case scenario, kind of paint a picture and see how potentially it could play out. Middle-aged patient with pancreatic carcinoma, severe visceral abdominal epigastric pain. Following the current World Health Organization ladder, we start with mild analgesics, anti-inflammatory medications. If unsuccessful, we move up to the ladder, add some adjuvant drugs, gabapentin, pregabalin, Lyrica, Neurontin. If still unsuccessful, we'd consider moving up the ladder to start a mild opioid analgesic. Oftentimes, this is still unsuccessful to control this type of pain, and we have to go even further and start a potent opioid analgesic. Hydromorphone, oxymorphone, Dilaudid. And very often, this does alleviate the pain short-term and long-term, but not without risk. Risk of depressing their respirations, slowing their breathing pattern, sometimes to the point where we even have to give a reversal agent, naloxone or naltrexone, to offset the effects of what opioids have on our respiratory center. Still to date, in 2023, addiction has no face, age, sex, or race. We can't predict what patients take an opioid analgesic and have this very high surge of dopamine levels. Those dopamine levels stimulate the reward center for the brain and can really take over their craving, preoccupation of their mind, and consume their thoughts. This begs the need for better drug development, better pain management. The cornerstone of our Hippocratic Oath is non-malfeasance, first do no harm. We have to alleviate pain in a safer, more effective fashion. So our current modalities of moving up the World Health Organization ladder and following the CDC guidelines sometimes leads us to a dead end. with pain control, but at the cost of dependence, addiction, withdrawal, and other comorbidities that coincide with it.
And where, Dr. Sabia, do you find some of the most promising alternatives as you go up that ladder to alternatives to opioids or more responsible prescription or delivery of the drugs?
Sure. So that segues into other modalities that I think are in the pipeline. 3 big categories: medical marijuana, ketamine, and targeted directive therapy with treatments. Medical marijuana is broken down into 2 main branches: THC and CBD. Tetrahydrocannabinol, which works more centrally on the brain, accounts for some of that euphoria, hallucination effects, lack of motivation, can help pain, but that's not the best pain-relieving component of it. CBD is cannabidiol, and that, through research, has demonstrated a very potent anti-inflammatory effect. There are modern technologies with biomedical engineering has allowed us to fractionate, splice, and isolate certain isoforms of these molecules. So instead of taking the whole compound together and experiencing these side effects, the future really lies on pharmacodynamic extracts to allow us to study those biomarkers and those individual effects on pain, sleep, PTSD, movement disorder, epilepsy. So this is where targeted therapies are directed in the future, is not taking one parent molecule, but an extract, a terpene, one isolate of it, and using it for an individual targeted therapy. Next to ketamine, it's been around for a century, still used in the operating room today as an anesthetic. We've learned through research that the active metabolite of ketamine is norketamine, and that has a very potent analgesic effect through its action on the NMDA receptor in our brain. So I think the future lies in the ability to synthesize norketamine and use that as an analgesic for many different types of neuropathic pain and centrally related pain. Small doses of ketamine can have large benefits in the Timber protocol that Dr. Pradhan discovered and patented, and it really helps disinhibit some parts of these deep-rooted memories that are ingrained in our brain that is hard to get through with conventional talk therapy. And finally, targeted therapies in the future. In 2023, still some of the most common reasons that we seek medical attention is for back pain. Pain from changes in our spinal discs. They can swell, shrink, protrude, degenerate, have cracks. These discs can leak their inner material out and release a substance called proteoglycans. These proteoglycans can cause a huge inflammatory response and signal the pain pathway, how our body sends pain signals from the spine to the brain. The future really lies in the development of some intradiscal gel injections that can be delivered inside the disc to seal these cracks, prevent the leakage of proteoglycans, and stop this inflammatory cascade.
Thank you very much, Dr. Sabia. The reason Dr. Sabia is the first panelist to speak is because very often pain is kind of the sharp tip of the spear, as it were, resulting in, you have addiction issues, and through the documentaries we saw with Riley, subsequent mental health issues as well. Where do you see opportunities if people come in for pain to work across with your other medical colleagues? You mentioned Dr. Pradhan and Timber. Are there additional places where medicine can interact better across disciplines?
Sure. Current consensus guidelines, the CDC and the DEA are constantly being updated. It's a full-time job really staying current and being in the know of what we should be doing at this day and age. The NIH, Mayo Clinic, and the Cleveland Clinic have all demonstrated an abundant amount of research demonstrating the multidisciplinary care model and format showing improved outcome, better patient care, mitigates risk and harm. Specifically to pain, this involves a team of neurosurgeons, anesthesiologists, pain medicine specialists, physiatrists, psychiatrists, physical therapists, and addiction medicine providers, all working together, adding to their individual expertise so they can help treat patients with their specific training. We are so fortunate that within Cooper, we have all these specialties under one system, and we are able to provide the best possible care for patients in the state of New Jersey and in the greater Philadelphia area.
Thank you very much. I think we'll move on to Katie Walker now. Katie, unique perspective as both a healthcare provider and also as an entrepreneur. And I've had many discussions with her about not only her journey from provider to entrepreneur to advocate and working with administrations, governments to provide the resources necessary, the legislation necessary to move things forward. So I would like to ask you, Katie, like with your journey, personally, how did you get into becoming an entrepreneur on top of being a healthcare provider? And then the second part, we'll maybe get into the obstacles that you had to overcome to provide the services you currently offer.
Sure. Yeah. So I'm still trying to figure out if I'm smart or if I'm dumb, because there's a lot of obstacles, and the growth curve is straight up. So my background, I've been a nurse for about 20 years. I worked at Level 1 Trauma Center in the ICU for about 10. Went back to anesthesia school, and I practiced anesthesia at the hospital. Did all the specialties, went to 5 hospitals for about 8 or 9 years, and then I thought it was a good idea to open my company now called Revitalist and to give ketamine infusions. And when I was in the hospital with the anesthesia part, like we give ketamine a lot, various ways, and I saw the data, and I was just amazed. I was like, there's no way this is real, right? So I would be sedating someone for ECT therapy, so the shock therapy, and I asked the psychiatrist there, and I was like, hey, have you looked at ketamine? And she's like, yeah, it's a fad. And I was like, all right, so I dropped it, and like a few minutes later, I came back, and I was looking, and I was like, I don't think it's a fad. Like this data, you just can't, you can't deny it once you see it. And so I opened the clinic thinking that I would have a better work-life balance, less call at the hospital, and then, part-time at the clinic. And when I sat down in the outpatient space, because I've grown up in the hospital system, and in the hospital system, we're amazing. Somebody comes in with a gunshot wound, we're going to call everybody in. Well, in the outpatient space, it's very territorial, and I had no idea. So I'm sitting there, and I'm hearing these stories, and I'm absorbing. I'm used to death and trauma and all this other stuff. I've been around a lot of stuff. And I'm hearing these stories, and like the youngest person we've treated is 12, the oldest we've treated is 90. I've had people, they'd come in, they say, yeah, it was a self-inflicted gunshot wound. I've tried to hang myself 3 times. Like all these stories. I've got 9 specialists. I've been on 38 medications, and I'm just sitting there, and I'm just like, I feel like I'm back in the ICU, right? But I'm in the outpatient capacity. And I was thinking, there's no way that one physician or provider, whomever, can absorb all of this. So I'm like, well, does your rheumatologist speak to your psychiatrist? No. Does your psychiatrist speak to your neurologist? No. Does anyone on your team speak to anyone? No. Okay. So I made the company to where it's a collaborative piece, right? Because I've worked with, in the ICU, fortunately I worked with all the specialties, and in the OR I've worked with all the specialties, so I can understand a little bit different language patterns between an obstetrician versus a family versus neurosurgery, whatever else. And so we've made it to where we can collaborate with people and we can advocate for them, because as providers, we make people feel horrible for advocating for themselves. So when patients come in with an article and they give it to you, well, you didn't go to medical school. So I'm like, guys, what are we doing? How are we helping these people sometimes? And sometimes I'm appalled, because everyone up here is extremely unique. But for the majority of the providers out there, we don't see the harm that we're creating all the time. So I think, looking at CBD, looking at ketamine, looking at psychedelics, it dissolves, kind of what Riley was talking about, is like it dissolves your ego, right? To where we put the person first, and then we see how does the system help the person, not how do we put the person in the system. So we're flipping the narrative with that. So open the ketamine clinics. I have a few now, and I kind of got tired of society telling me I didn't know anything about mental health. So I went back and got my psychiatry degree. So now I have my anesthesia and my psychiatry degree, because in that way it's just like, just tell me what you want. Whatever you want, I'll jump through the hoops, right? So it's, so we've seen this, right? And I played collegiate sports, and I understand a little bit, not necessarily half of what Riley is. I tell people now I've been around true athletes. But there's so many underserved populations out there, so many. And in the outpatient capacity, we think we're meeting them where where they want us to meet them, but we're not, right? We're still learning. And, you know, to see that therapists and psychiatrists and the medical providers, they don't respect each other across the board, right? So, I mean, psychiatrists, you know this, I mean, most psychiatrists don't speak with therapists. Most therapists don't speak to psychiatrists. Heart surgeons think psychiatrists are crazy. Psychiatrists think that, you know, and it's like, we're all like stepping on each other's toes, and then we have like an 80% shortage of providers. So we got to step back and say, okay, wait a minute. We all have deficits, right? From anesthesia to psychiatry. One knows certain specialties and more so than the other, but the neat thing about psychedelics and ketamine and CBD is we all can step back and we can say, hey, I've got a weakness here. Can you help me train with this? Because it's the discipline that's going to involve all of us. Exactly what Dr. Sabio is saying is it involves all of us to work together to achieve the common outcome. And like Riley was saying, you know, the diagnostic aspect, you don't have to have a diagnosis with this. It's treating the symptoms that people are struggling with, right? And it's muting those symptoms and allowing that person to actually start healing. So there's so much here, and if you can tell, I'm slightly passionate about it. I don't have a better work-life balance. It's absolutely horrible. But every minute, you know, that we don't push forward, I feel like somebody's dying. So I'm really happy to be up here with everyone here.
And Katie, a very interesting part of your story as well is your advocacy with veterans and your ability to get veterans into your clinics and to get reimbursement from the VA. Maybe tell us a little bit about how you approached the VA, how you were able to get the buy-in to help reservist members with their health issues.
So that was a unique piece with the veterans as well, because when I told them I was an anesthesia provider working in the mental health space, they kept on telling me I was a pain clinic, and I said, I'm not a pain clinic. So the VA actually denied me 9 times before they actually let me in to get a VCA. So I nagged them enough to where they let me have this contract called a veteran care agreement. And veterans who meet their protocols, basically they just have to have failed 2 forms of therapy. And it doesn't have to be medicative therapy, it can be different forms of. But as long as they have failed 2, the VA actually covers their ketamine infusions, and it's a federal contract. So I try to get in front of as many veterans as possible because it's one treatment sometimes with ketamine literally saves someone's life, or it gives them the hope that they need to continue to improve. But we've had a lot of veterans. I've had snipers. We've had people who've tried to kill themselves several times, IV drug use. You know, just all sorts of situations. And some of these guys and gals are actually in remission of their symptoms, right? They're actually sleeping. And one thing that we've noticed with ketamine specifically is a lot of times, you know, depression, anxiety, trauma, insomnia, and suicidality, those all coexist at the same time. So unfortunately, when people come to us, they're usually on their last limb, and it would be really nice if they would come to us after they had only failed 2 therapies, not failed 2 therapies, been inpatient 10 times, had ECT, you know, 2 rounds of that, right? So, but unfortunately, that's how we train people, right? Right now, we're telling them that ketamine is kind of the last leg for them to come to. So it's really amazing that the VA is covering this. And then, you know, if we could push this out to where it's a treatment option sooner rather than later, I feel like our society would be a little bit healthier.
I'd like to thank Katie for being so generous with her time as well, working with us and Dr. Pradhan on exploring ways that Cooper can expand their services in this space and learning from your experience. And next up is Dr. Pradhan, which is a great segue. Researcher and clinical provider, background as a Buddhist monk, but also as a psychiatrist. Just a phenomenal synthesis of mind and body knowledge. I got to know Dr. Pradhan almost immediately after I joined. We met for coffee and formed a bond. I have a neurophysiology background. I found it amazing that somebody encompassed this breadth of knowledge and approach to medicine. So I'd like to ask you about your background, Dr. Pradhan. So how did you end up in this auditorium at the meeting between the brain and the body and looking at treating these seminal health issues of our time with a holistic approach?
Thank you. Yeah, I want to first express my gratitude for all of you coming here and our chair, Dr. Rosten, who has been my mentor and really the guiding light for the mission I have taken up with Neil and the whole group. And I'm grateful personally, some of my patients are in the audience. And when I did the first ketamine trial in America for PTSD, between 2014 to 2017, 3-year longitudinal study, at that time, ketamine, we didn't know a lot of it, the mechanism and the action and everything. So at that time, we did a pilot study where we actually figured out beyond what dose of ketamine and beyond how many infusions it will be harmful rather than beneficial. And once we figured that out in the first pilot study, then I took up a project which brought my background as a monk and as a neurologist, as a psychiatrist and a child psychiatrist, and as a meditator into one treatment called TIMBER. And TIMBER, it's an acronym where the meditation can be used to strip out the emotional and the fear memory from the trauma database in the hippocampus, amygdala, and the cortical area. Before, I specialized in India in truth serum, sodium amytal, and I got the Prime Minister of India medal actually for that work before coming to US back in 2005. And then I came to US, Jefferson University, Jefferson Neuroscience, upon invitation, because we discarded a predominant theory of neuroscience in schizophrenia and bipolar disorder. And when I joined Jefferson Neuroscience, they have amazing integrative medicine center. I was telling Jessica today actually that my mentor, Andrew Newberg, we actually put the Tibetan and Vietnamese monks into MRI scanners. And we studied how their brain is different from regular, like our brain. So that discipline, amazing, like it's a confluence of philosophy, medicine, mysticism, religion, humanity. And we figured out what in Riley's documentary, and the scientist from Shepard Pratt, Scott Aronson, what he's saying, the default mode network, that's actually the default mode network is actually very low functioning in monks. Because when the default mode work is very high functioning, we think that's a patient and I am a doctor. When the default mode network is really weak, which can be deliberately weakened by psychedelics, by brain stimulation, what I do, non-invasive brain stimulation, by figuring out which part of the brain we can target with a wave of magnetic energy, and how to quiet the default mode network to make the selfish people unselfish. Isn't that amazing? That we can change the selfish part of the brain to become compassionate. And that's what we embarked for 3 years in Jefferson. Then back then, my friend all advised me not to join Cooper. He said, you'll be robbed in Camden, don't go, right? But our chair, Dr. Pumariga, back then, we didn't have a neuromodulation division, we didn't have a mindfulness division. And 1 month before I joined Cooper, there was a horrible news in the media that one mom caught her baby and put in the fridge in Camden. So I said, that's definitely the place I want to go. So I left my, I was almost signed up to be an attending scientist and clinician researcher in the Integrative Medicine Center in Jefferson. But I joined Cooper and I brought the neuromodulation machine with me. And we started that division 12 years back on July 18, 2012. And now, last year on July 18, we started the first fellowship in North America, which is called the brain stimulation, using non-invasive brain stimulation, psychedelic and mindfulness therapy, which is truly, if I die tomorrow, I will not have regret because we have established that. That's what I have lived for in my medical career so far.
Well, don't die yet, Dr. Pradhan, because there's still a lot to do. But I know looking forward with your fellowship and the opportunities working across Cooper and with your colleagues in, in pain, addiction, and with the holistic view that you bring, where do you see the opportunities to grow? I know you have an acronym NIMBUS for the initiative that we're putting forward to expand services and research, clinical research, to provide evidence-based medicine approach to the fantastic documentary and the sort of approaches that Riley helped expose in the documentary.
Thank you. So the journey we have embarked, the thing about Cooper I wanted to say, I want to speak my heart, that Cooper is a family for me. And it's I could have gone to Harvard actually if I wanted. I could have gone to Hopkins, but I stayed in Cooper because I believe in the people, in Camden population, the trauma. To me, people of Camden and people of Compton, California are no different. And if we can work with Cooper, and if you work for the Camden population, you can heal anybody on earth. So this journey is difficult, but it takes a village to help Camden population. The first thing we should do is what we are doing, that bringing all our scattered discipline into one umbrella called NIMBUS. And NIMBUS is an acronym which is basically called Neuromodulation Institute for Mind and Body Utilization of Service. So that means we are working in silos and not integrating like Katie mentioned before, but we have all the discipline we need inside Cooper, and we have to just bring them in one umbrella with 3 goals, and I call it like a Nimbus trilogy. So the first trilogy is basically how to integrate among ourselves, how I talk to Dr. Sabia, how I talk to Dr. Lemon, how I talk to Dr. Korchop, how I talk to Dr. Goodman, across the discipline, to have a cross-disciplinary talk in the service of the patient we are trying to heal. That's the first level. Second level will be, after this collaboration, how to bring one platform for clinical utilization of all aspects of neuromodulation, all aspects of brain mapping, all aspects of ketamine, all aspects of yoga or mindfulness therapy, neurorehabilitation, physical medicine and rehabilitation into customized treatment programs. Then second part will be with Dr. Lemon and our Innovation Center, how to take it to the next level to develop customization of the biomarkers so that we can do personalized medicine and mind-body medicine practice into very specific way and in disorder-specific way. And third level will be how to educate our young students and how to retain them in Cooper and how to develop new fellowships, new training program, and how to train our therapists or providers into these new models. So that's how I see the 3 goals of the Nimbus, and that's how I think the field will grow with us.
Yeah, it's absolutely fantastic having principals like Dr. Rostein, Dr. Pradhan from psychiatry, Dr. Sabia looking at pain. A kind of a third leg to the stool as well is addiction medicine, and Dr. Bastian, who is the director of our Center for Healing, who is also working with us to make sure that we plan for the future to even greater increase the cross-disciplinary interaction and holistic treatment for people suffering at that axis of pain, addiction, and mental health. I'd also like to thank Mark Stevens from Enable Health, in particular, for introducing me to our final panelist. Jessica Tracy has, I had mentioned, backgrounds in multiple areas, which are very applicable to this topic. And Mark also introduced us to Riley Cote, which, without that, we probably wouldn't be having this event right now. So, quick question for you, Jessica. I believe a good part of your initial part of your career was in the insurance industry, right? You rose up to an executive position there. Have an understanding of the payer's perspective in the health insurance business, and then made a transition from that into a health executive space and patient advocacy space. Where in that journey did you then interface with kind of some of these alternative natural health opportunities, alternative treatments for addiction, pain, in mental health.
Sure. So, yeah, I'll start with a little bit of my background and then share how I got to my own experiences with these alternative healing modalities and then how it brought me here today. So I've got about 15 years of healthcare experience, diverse set of background, about 10 years in insurance and employee benefits consulting. I spent some time as an underwriter at IBC here locally. I also did data analytics, diving into claims experience, looking at health challenges, cancers, mental health issues, and using that information to then put together cost containment, health and productivity solutions, really just strategies around looking at a population set of claims data and saying, okay, here are the key conditions that I'm seeing within this population, and then what are both the insurance designs that we can build and put together to help people make better decisions on what care they can get. How can we make sure they're getting access to the right care, the value-based care, the care that's really going to drive the right outcomes and right initiatives, and then also looking at some kind of integrated services around that really just like keeps them well. So I spent about 10 years doing that, working with employers, unions, public sector groups as well. And then from there, I transitioned over to the startup world, which I really enjoy, very fast-paced. And there, the focus was looking at how do we build the appropriate levels of access through innovative delivery models that sit around sound clinical protocols. So not looking at changing any clinical protocols, but really creating these access points through innovative technology, as well as just understanding patients' needs in general, right? Some people can use technology, some can't. Some need to, be there in person to get a service. Some need to use telehealth, some need to use their cell phones. So really just taking this kind of a really deep understanding of, okay, what is, for each unique population, what are the needs around access, and then how do we build these solutions and delivery models around that. And the work there focused around increasing access to clinical genetics, a lot of that focused on increasing awareness, and then creating a better delivery model around that also increased and reduced the cost for the model as well. So that's a bit about my background, and then through that I've always been an incredibly hard worker, working probably way too many hours, and putting probably too much pressure on myself, and with that came with a lot of anxiety. I've dealt with anxiety for a majority of my life and into my adult life, and also struggled with insomnia issues. And I went through the traditional care pathways with that. I did CBT with a ton of different therapists to try to find the right one that worked for me. I also used pharmacology, so SSRIs, to help manage my anxiety, and I used Xanax for insomnia, all prescribed as the appropriate treatment path for me. And after probably about a decade of using that treatment plan, I was still stuck. I wasn't finding the right healing. I was still struggling with those challenges. And I was pretty high performing in my role, and I think that probably caused a lot of the insomnia challenges that I was dealing with, but then it kind of layers on when you're not sleeping. Then you're like, okay, well, I know I'm not supposed to use this Xanax often, but I need to sleep, right? I need to sleep. I have this presentation tomorrow. My role was being out there presenting, talking to people. So for me, I just felt it was really unsustainable. This may work for some people. For me, it was unsustainable, and it did not feel right for me. And it honestly, I started to really feel the side effects with this as well. It was kind of like words weren't coming to me as quickly as they should, and kind of the traditional negative outcomes of using Xanax for sleeping and how that builds up. So I then had an experience with psilocybin. I was international, and I was able to try psilocybin for the first time. And for me, it just opened my eyes to all of, I would say, what was causing the anxieties, what was causing my challenges with sleep. And, you know, after that first experience, it wasn't like I had a silver bullet and I knew exactly what to do and, you know, all my problems were solved, but I at least saw, right, what needed to be fixed and what needed to be done. So from there, I had experienced it with it a few more times, and it just completely changed everything for me. And I was able to see, okay, these are the areas that I need to focus. I was able to also find additional modalities around healing, like yoga, meditation, just other different types of ways that I can pull, that I can focus on myself and not need the traditional pharmacology that I was using before. And after those few experiences, and seeing what a profound impact it had on me, and how quickly it really helped me to start making changes. And I really, which is something that I tend to do if I get really interested in something, I just went down the rabbit hole, right? So I started to do a ton of research on it. I started to, look at clinical trials. I started to realize that there were companies out there that were doing this. And for me, it was like, okay, this changed my life. This really helped me heal in a way that I wouldn't have been able to heal if it weren't for these healing modalities. And I really wanted to create the awareness and the education around this for everyone, so that they could make the choice, so that they could see that this was out there as an alternative solution. And now it's been two plus years since I've had to use any medication for anxiety, for insomnia, and I sleep almost 8 hours every night. I've used traditional therapies like CBD. And I really don't have any anxiety at all, really. It's pretty amazing. I pulled in yoga, I pulled in meditation, but I mean, I've been able to, 2 years off my medications, have like slight bouts, of course, probably a little bit before today, but, not really having any anxiety at all, really being able to just get to the root cause and really just create additional awareness and really evolve, I would say. So from there, I just really went deep into understanding this, to learning this, and I started to reach out to different companies to learn what they're doing in this space. I was really fascinated about all the different practices that are out there, and I came across a local ketamine clinic in West Philly, Sound Mind. And I reached out to her and I said, look, I want to be involved. Somehow I need to be involved. So she said, well, the best way is to take some courses and get certified and learn. So now I've taken a few different clinical certifications with her, really all around the research behind it. The integration practices that are necessary, the mindfulness practices that a clinician or a therapist really should be practicing as well, so they're not having any type of burnout or anything like that. So I spent a few years getting these certifications, meeting a ton of people in the space, and then organically started to realize that, wow, there's a lot of these clinics out there that have these really great models, but something's missing, right? They would either be missing, there would be a medical professional that didn't have really this kind of like business aspect, right? And you would see like capacity issues, or you would see being able to reach and engage patients, or just kind of operational structures that were impacting the business. And then you would see people on the other side that were looking purely at this from a profit perspective, and they would say, oh, there's a lot of money in here, and I know I did this for cannabis, or I did this somewhere in here, and let me just jump in. And then you're seeing, they're not following some clinical protocols, they're burning out their therapists, which is a major issue. They're cutting quarters on certain things. So I just started to really see a lot of what was going on in the space. And then really just a lot of the access challenges too, which was one of the biggest concerns, and my biggest area of focus is access, right? How do we create education, create awareness around this, and then also ensure that it's affordable? And I know we're going to talk about insurance, but so that's kind of my background. I organically started to advise for companies, and now I'm doing that full time, and really just kind of, I would say, bridge the gap between psychedelics, business, insurance, and access is really how I look at this.
It's very interesting because there's also kind of some underlying themes regarding kind of personal stories which result in experiences in this space which turn into advocacy, which you've exemplified with the ketamine task force, Riley clearly with Wake and the documentary we just watched, Katie with Revitalist and the opening up of the ketamine clinics. You're right in identifying like access and barriers to entry as a significant theme that Cooper is looking to help overcome with the establishment of additional resources and facilities to enable some of these treatments. Maybe I'll open this up even to the panel regarding some of the barriers that you've experienced personally, you with the ketamine task force trying to broaden access out to different groups, dealing with payers, Katie the same thing, trying, with the success with the veterans, but there's many more people that could use those services. Dr. Pradhan's done many research studies using ketamine, but we don't have a Schedule 1 license as of yet to use psilocybin, and that's a barrier that we're trying to overcome, talking to consultants and wanting to get that up off the ground. Dr. Sabia has been on the front line of pain treatment, seeing some of the negative externalities with opioid use, but kind of working on precision alternative methods. But barriers to that too, like prescribing the opioids, OxyContin, it's cheap and easy and it works, right? And there's a reason it's prescribed. So maybe I'll open it up starting with you, Jessica, as far as kind of those barriers.
Yeah, access is a huge issue. When I think about patient access, I think of a few things. I think of the awareness and education piece, which is huge. So that's one area, and I think stories like Riley did and other stories and documentaries that are out there are really important to help drive that forward and create that awareness. But the other piece of it is the affordability. So there's some clinics that are able to get reimbursement from an insurance perspective. The majority of the clinics that are out there are doing direct pay, but the reality of it is there's so many people that cannot afford these services. They're costly. It's $6,000 for 6 set of treatments in that range. People can't afford it, right? So it's definitely a major issue. What I do appreciate is I do see that there's a lot of emphasis around trying to get these things covered. From an insurance perspective, there's companies out there that are doing time-based billing to help kind of get the right reimbursement models. There's innovative organizations out there that have built a third-party administration system where they literally built almost an insurance company and a network of ketamine clinics across the country so that they can bring that to employers, to unions, to other populations, so that if they say, okay, employer, yes, I believe in this and I want to offer this to my employees, they can kind of put some money aside and then work with this TPA to process and adjudicate claims so that they can get access to these services at no cost. So I'm really grateful to see some of these initiatives driving forward, or I would say innovative solutions out there. And then, Cooper, the fact that you all are being on the forefront, being innovative and saying, yes, I believe in this, and yes, I want to put something together to make this possible, is I'm just, one, incredibly grateful for, and two, I think it's what we need. We need a health system to say, I believe in this, I want to do this, and to make it available in a sustainable way. Because I do think there is still some hesitancy, so when you do it through a health system, people are going to be a bit more comfortable with it and open to exploring it.
Absolutely, and I think definitely one of those barriers is a lot of the health provision currently is based on kind of a patenting model reliant on patented medicines, and it's a bit of a space I live in. Before I got into tech transfer, I managed a drug development program focused on pain in Ireland for 3 years. And a lot of the money that goes into those trials come from the monopoly that's provided by the patents to protect those compounds, so you get a return on your investment for those trials, right? The natural medicines are free for all. There isn't necessarily that monopoly that's available to make that investment. So you have kind of a weird tragedy of the commons, right? Like the solution may be out there, but because nobody can directly monopolize the benefit from the expense to prove that it works, we end up in a bit of a stasis. So we're hoping that Cooper can kind of break that logjam, working with a lot of passionate providers who are interested in breaking that logjam, be it going out to get federal grants, state-level grants, working with payers. Jessica has a great experience working with all those stakeholders and has been helping us help put together a plan to break that logjam and offer treatments through Cooper. Maybe if I open up, like I remember one of our discussions I had with Katie Walker, we were discussing about a certain treatment, and we were thinking, oh, well, you know, this seems to work. Your clinics are full, the ketamine opportunities are great, but this particular treatment, I believe you piped up, and it was $75,000 a year, right? For the is an organ, yeah. And I'm like, oh, well, you know, that is a major barrier to coverage, right? To broad coverage. Maybe talk to you like how you were able to, you know, get the VA as an initial early adopter into that treatment, and where you think we can eventually do the most good, say, looking at Cooper to bring more people in to provide the health care they need.
Yeah. You know, I mean, I think that's the beautiful thing about ketamine, right? So it's been around since 1970. I mean, it's over 5 decades old. And we use it in every capacity. So we use it with pediatrics, we use it with moms who are having C-sections, we use it in cardiac surgery, neurosurgery, just across the board, we use ketamine. There's no other drug that we've done this with, right? And it's on the World Health Organization's list of essential medications. So every country in the world has access to ketamine. So, you know, kind of a false pretense is, and this is where a lot of providers get very hesitant, and clients and patients and everyone else, is it's being used in an off-label capacity. And, you know, and you hear this, it's being used in off-label. Well, the interesting piece of that is about 80% of all mental health medications are being utilized in an off-label capacity. So it's following the exact standard of care that is out there now, but no one's ever asked those questions. So, you know, so the more that we can educate, the more that we can validate, and I think this is the beautiful thing about ketamine, and, you know, psychedelics too, but especially ketamine, is it's an old drug and it's scientifically proven. Like, there are neurologic patterns that we can prove over and over and over. Like, I've had people say, are you a wizard in ketamine? I'm like, no. I've been in like 12,000 infusions, right? So I see consistent patterns over time. And what Jessica was saying, it's like, you know, with ketamine and psychedelics, it takes us to the root cause. So a lot of people, I mean, in like neurodegenerative aspects too, Parkinson's, dementia, MS, ALS, there's all these beautiful studies out there right now with ketamine. But what we don't see is like the current system that we have. What Jessica was saying is, you know, we give medications to suppress symptoms, but whatever is underlying continues to duplicate itself. So when I'm talking to people, I'm trying to figure out, I'm like, how can I connect with these people? How can I get them to see that this drug ketamine, that's also a horse tranquilizer and date rape and cat Valium and all this other stuff, all these horrible names that ketamine brings along with it in its little career. You know, I'm like, how can I connect with these people specifically so they can understand that what we're doing works? And the biggest piece, I think, with the advocacy to where I can really connect with people is to say, you believe in muscle memory, right? The whole world believes in muscle memory. Well, the amazing thing, our muscles don't have memory, right? They're just fibers. They contract, they relax. That's all they do. And it's our brain that's controlling our physical aspect of the muscle memory. Well, your brain also controls the behavioral aspect, and it duplicates what it knows. So I always ask people, I'm like, when did you get depression? Oh, 25 years ago. Okay, is your depression worse now than it was? Yes, so much worse. And I'm like, well, but after 25 years, you've been on all these medications, you've increased your coping mechanisms. Don't you think that if it wouldn't have duplicated until now, that you would do better? And, you know, and it's like this aha moment. They're like, yeah, you know, and they're like, nobody's ever talked to me like this. Like, you know, so there's something here, and we all see it because we've been in it. But it's access, it's pushing, you know, it's pushing the envelope, it's having people tell you that you don't know what you're talking about. And I invite people all the time, I'm like, just come sit with somebody. You know, come look at the veteran, come look at the police officer, come look at the 12-year-old child who's tried to hang themselves 5 times, who's now back in school, you know, 3 years out, right? You can't deny this, but we're so stubborn. Like, we are so stubborn in medicine, and we think we're so smart, and, you know, that when we graduate, there's no way there's more data out there than what we know. But now it's to the point, I'm like, were we taught wrong? You know? I mean, because a lot of the textbooks out there, the data, it's not out there, right? It's not in textbooks, what we're seeing right now. And textbooks are all old as well, but you know, it's just the more that we see this, the more that we have to push, and that helps with the barriers. But even at the VA, I have to call the VA pretty often and tell them, yes, you do cover ketamine infusions, because they'll tell me they don't. And then I send them their protocols and say, yes, you do cover ketamine infusions. Then they'll send me the patient back. Okay. So there's a big lack of communication for sure across the board.
Definitely, I think we've run the kind of breadth of like kind of looking at holistic approaches, systemic approaches. If we're like looking at psilocybin, ketamine, you know, traditional opioids that were systemically took, OxyContin, and like precision approaches, which Mike touched on earlier. Dr. Sabia, sorry, I should. But I'm thinking there too. There's also alternatives. If you're starting to look at pain systemically for mental health issues, unexplored treatments or treatments which currently like ketamine, psilocybin, which you know we need to gather clinical evidence and we want to really push forward. But some of the non-opioid precision applications or even opioid precision applications, I know we've been speaking with Persera that has you know some cold therapy type applications, other applications. So we don't go down this journey towards addiction and resulting mental health opportunities. Do you see a shift over the last year, 2 years, 3 years, 5 years, Dr. Sabia, in acceptance that maybe the harm is greater than the good with some of these systemic treatments?
Yeah, absolutely. The pendulum's swinging in the right way. At the very least, it's created a stream of events like today to notify the public and the media of our current model really isn't sustainable. If it was working so well, there wouldn't be people like us and panelists telling the communities in the world that we have to look at other areas of how to treat patients in general. So there are so many opportunities out there in current drug development and interventional treatment development that have a lot of promise. And now we're just so fragmented. We're using one segment of it, maybe only a small portion. So we're moving in the right direction. The world, the media, the news, the public is seeing the harms of the past from some of the decisions that we made with the information that was the best we had at that time. But at the very least, it's trying to still continue to disseminate the information of this multidisciplinary care model. You have pain, you have mental health issues, it shouldn't be so fragmented, so siloed. Go to Dr. X and then Dr. Y. Go to this center that has exam room A for this treatment to watch a video on behavioral therapy. Then do a yoga session. Then maybe get a treatment. Then maybe get a scan. Then listen to some behavioral group therapy. It's really going to a one-stop shop that holds the future in healthcare that's going to improve outcome and not continue with this current broken model of going to different towns and areas throughout your county.
No, it's very good. I'm very optimistic that Cooper is definitely working in that direction with the principles from those different areas of the health system. So I'd like to open things up. If there's any questions, we have a microphone strategically placed in the middle of the room. If you have any questions for the panelists or any comments that you'd like to raise for discussion, please don't be shy.
Can I just give more information on the discussion? So ketamine is definitely special. It's a psychedelic, but it's a special psychedelic for many reasons. First, from research perspective, it is less restrictive because it's Schedule 3. Rest of the psychedelics are Schedule 1. So when I did the first study on ketamine for PTSD and potentiated that, we potentiated ketamine duration of action by 7 times. Like our patient improved from 33 days to 72 days with single infusion when we added meditation or timber on ketamine. So those are all easy. The reason we are struggling with psilocybin or other psychedelic is because they are Schedule 1. So that's a good news. Second is, ketamine is called ultra-rapid antidepressant. There is no ultra-rapid antidepressant until ketamine was tried. And that's very important to remember because When my friend became a cardiologist, he takes 1 week for the patient's heart condition to be reversed. I joined as a psychiatrist back in 2001, and we cannot even treat a simple depression. We take 6 months to treat, and only 40% people improve, 60% don't. Why so? In that context, ketamine is mind-blowing because it can improve the depression and suicidal symptoms within 40 minutes. Within 40 minutes, we have seen transformation. That's the second part. Third part, ketamine is extremely cheap. 1 bag of ketamine is only $18 when I did the trial. $18. Right? A Prozac is $60, right, for 1 month supply. Forget about new medicine, so more pricier, right? Fourth thing is ketamine can induce people with PTSD into meditative states. That's how it's psychedelic. And ketamine also reverses the suicidality. Ketamine also can improve the pain. So what we are trying to do here is basically the access to all these interventions, like Jessica said. Not only we have to lobby, but we have to also not to reinvent the wheel too much. We have to really capitalize on what is already done and how to gather our manpower and our infrastructure to build a platform and how to bring it to the needy people. That's really important because you don't want to, when the mountain is too high, you can go around the mountain to cross it. You don't have to drill a hole and go through it. That's too pricey and almost undoable, right? So better to put a helmet on the head rather than going through a vehicle by collision. Right? Just wanted to open this up because there are many barriers, but all the barriers can be handled in a lot easier way. Scientific and more crafted and more organized way. Like Katie and Jessica are involved with, a legislative piece where people are actually trying to have the veterans sign up and approach the lawmakers for compassionate grounds, right? Mm-hmm. And that's how the psilocybin in Hopkins got breakthrough status through the lawmakers. So those processes will take time. But I'll tell you, good news is that a variety of ketamine products are approved by FDA. They are reimbursed by insurance, like S-ketamine, for example. All the brain stimulation services are reimbursed. I routinely treat them, and insurance pay for it. Mindfulness therapy is reimbursable. So one of our main goals is how to provide the services to the community who are waiting, and they are the deserving people actually, so that we can bring also clinical improvement, not to just wait for 10 years for FDA to approve and then go in that route, how to bring the services so that we are ready when FDA approve it, we are one of the first people because we already have thought about it 10 years before other people.
Mm-hmm. I should add as well that a lot of the psychedelic use for mental health, we're looking at procedural application as opposed to chronic application as well. So the length of use combined with mental work, so far the research looks pretty promising. We hope to expand on that with the team here at Cooper. But additionally, this is one of the areas that we have rare kind of bipartisan support. So the Breakthrough Therapies Act was sponsored by both Senator Booker and Senator Paul, right? Who, if they can both see clearly that there's a benefit in this, it's not a right or left issue, it's a human issue that everybody can get behind. Mm-hmm. So I think the time is really ripe for the efforts that everybody at Cooper is putting forward and given the evidence so far to move it along. So yeah, we'd really like some engagement with the audience. I know Mark seems to be wanting to ask a question.
I'm trying to stay warm over here. No, thanks, Scott. Mark Stevens from Enable Health. I was thinking, I have so many questions, guys. First, thank you so much for doing forward thinking one question I would like to address the panel and to Cooper as an institution. So Camden, the three leading employers in Camden are Campbell Soup, Cooper Healthcare, and the Camden County Jail. So there's a great opportunity when we look at innovation and a great moral imperative that we look at correctional healthcare. We look at also newly released inmates. Cooper has a tremendous relationship with correctional care in Camden, and a lot of people are a lot better for it. But there's also a lot more opportunity for us to have an impact in that space, including through the medical school curriculum changes. What opportunities does the panel see and does Cooper see? How are you going to use our experience today and some new modalities of treatment to affect that population?
Yeah, I think definitely the missing member here would probably be Caitlin Bastian from the Center for Healing, and they're expanding the number of providers under that center. One of them is actually focused directly on the corrections space. So Cooper isn't currently a healthcare provider in the county jail, but we do end up seeing a lot of the patients as they leave. Dr. Kirchhoff has a lot of experience as heading the trauma department, as well as about 100 other things at Cooper in his past. That Cooper does pick up the pieces when the system fails and the patients come in our door. So it has been something we've been looking at with the Beth Nice and the coalition of doctors that do work with us. I wish Caitlin was here to talk about all the work they do in the addiction space, interfacing with the corrections community, but they do great work. Maybe I'll let one of the people with an MD degree answer that question as well.
I mean, I think, Mark, we talked about this before last year, I think. One good way will be to have an extended contract for mental health services and for more effective treatment of their depression, or many of the correctional facility people have been traumatized and suffer from PTSD, drug addiction, chronic pain. So how to bring to the forefront the treatment, and then how to train also some of the Cooper provider for extended kind of approaches, like for example, how to train them into mindfulness therapy, or how to do medication assisted MAT, medication assisted therapy for addiction, like for quick detox, and how to do rehab, or how to integrate them into like the mainstream medicine, because they are kind of like a secluded population and don't really get the adequate health care despite all the attempts. So to extend a contract with the Camden correctional facility and establish a care pathway and rehabilitation, that is basically on the horizons as we are speaking.
And I'll add to that, give Cooper some ideas. I've spoken to some judges specifically about ketamine because there's a lot of judicial systems that are starting to create mental health courts as well as veteran courts. And with the veteran court specifically, it's kind of like they don't want the vets to get in, especially if they've had a nonviolent crime. So the judges are all for sending people for ketamine infusions specifically. There's also some really good data coming out, and I go down rabbit holes like Jessica was mentioning the other day, or just a second ago. But there's a lot of good data coming out showing that emotional intelligence, the lack of emotional intelligence, is actually increasing suicidality. But then if you start going down another rabbit hole with psychologically abusive relationships, that's where it makes the connection that suicidality and homicidality coexist. And it's either due to physical abuse or psychological abuse. So the more, my personal opinion, the more that we can increase people's emotional intelligence, which is what psychedelics and ketamine allows us to do so beautifully, the more that we're able to decrease suicidality as well as homicidality. And then if you look at the jail system, the prison system right now, someone said the other day, it's the biggest mental health institution there is in the country, right? So we've got to start somewhere, because a lot of these people, if you've been around people with active addictions, they have no self-introspection.
They're in survival mode, period. They have no reflection. And there's some really great data coming out with ketamine where it's treating addiction as well. So it's like we can disconnect the brain from all these symptoms, and the person's like, oh my gosh, I feel like myself again. And they're actually in this peaceful meditative state to where you can actually work with them and they can connect with you again. They have that empathy for themselves, for other people, and they didn't think they could ever get there. So yeah, to speak about the gels and such, I mean, I think that's a beautiful way to get the states involved to start actually having really highly effective treatments.
And I should mention from the Innovation Center perspective as well, and we've worked with Mark a good deal looking at transition of care issues as people leave the corrections kind of institutions and reintegrate in life, that there should not be a drop-off in care and that they should be brought in and covered, and so we don't end up seeing them for the first time in the emergency. And towards that end, we're hosting a hackathon focusing on SDOH. Transition of care out of corrections is a focus of that, trying to bring in people from the community broadly that have an interest in improving the reintegration of people from that system in a healthy way. So that's going to be commencing in the fall. Registration will begin in September, and I'm hoping that we come up with some solutions to some of those issues that with corrections health. Nini?
Yeah, I've got a question. First of all, shout out to my Athletes for Care brother, man. Thank you so much, man, to come together at Cooper and make this all happen. Just so blessed, grateful, and thankful to have you as an athletic brother. I appreciate you. You touched me deeply, and I think I need to go with you and Jess to Jamaica because I have unresolved issues. You made me cry. Like as a retired elite athlete, as an Olympian, when I stopped playing, I was majorly suicidal. We have a whole conversation over dinner and drinks on that one. But I had, when Jake Plummer approached me, the former quarterback of the Denver Broncos, and introduced me to Athletes for Care, he said, Nini, how is your chronic pain? And I said, it's brutal, man, from the 10 years of training, and I had tried everything from steroid shots to opioids to physical therapy. And he said, had you ever heard of CBD? And I hadn't heard of CBD. And similar to Jess, I went down, and Katie as well, the proverbial rabbit hole. I did some massive research. I decided to join a CBD startup company that I ended up growing and selling to a Canadian firm. But while doing that, in my research, I came across Dr. Raphael McCoolum and became friends with him and joined his advisory board in Israel. And God rest his soul, he just passed away about 45 days ago. And as you know, we have these CB1 and 2 receptors in our brain, and we use that education, as Jess so eloquently stated. We need to infuse education. It's a massive, because there's such a stigma. And so what I'm getting to is what we did was we educated people that CBD is not a Schedule I. It is 0.03%, some say 0.04%. It is legal in every state. And the root of every chronic condition is inflammation. It goes right to the inflammation. It changed my entire life. I used to have to sit down like an old lady to put my pants on. Like I could barely even function. The arthritis was just brutal on the right side of my body. So I guess my question is, you've got people like Regina Holiday, probably the #1 patient advocate in the country, on the Hill in DC. Are there any thoughts about engaging her on the front line? And clearly I'm thinking this is the perfect person to do it right here. I can already see her leading. These two are just a powerhouse couple. The point being is that patient advocacy component. Have someone like Jess on the Hill and educating the masses top down. I met with the Surgeon General, and we ended up changing the world anti-doping rulings, and this was under Obama. And now athletes are allowed to have CBD 2 hours pre, post game. You absolutely have to infiltrate policy at the Hill level. And I hate to nominate you, but I think too late, it would be simply brilliant.
Yeah.
But I'm thinking, is there a way that I could humbly broker an intro to Regina and
Oh, you definitely can, and there's efforts within Cooper as far as advocacy on the Hill, some on the addiction space with Caitlin, but also at this intersection of pain and addiction treatment and alternatives like CBD, where we've we've had discussions with Jessica. There'll probably be news coming forward about things we're going to be doing on that front, and obviously we very much appreciate your introductions because you've been very helpful in the past.
Sorry, Riley, I'll get a kitchen pass.
And like especially your experience in the CBD space, we've been working, Dr. Sabi and I, kind of looking at doing investigator-initiated trials for lower back pain using CBD and finding the right commercial partner to facilitate that or the right granting agency to support it. And this all kind of flows into the broader opportunity to expand research services at this intersection of addiction, pain, and mental health, which are our principles on the clinical side are supportive. Yeah. And then we can spread our Philopodia through your connections and hopefully suck up the resources to make it happen.
Put my ladies, ooh,
Yeah.
I'm getting excited.
Very good.
Jenny, in the advocacy, we have a Cooper Medical School where we are sitting, and our students, have tremendous interest into psychedelic research. In fact, two of my students.
That's what I was going to ask you.
Yes.
Who's leading in this mushroom space? Is there a Dr. Raphael McCool? Is there someone that's leading that?
That's the plan. So basically, we have basic science researcher in Rowan University who specialize in psychedelic medicinal chemistry. And then we have students like Edward and Ankit, they are sitting in the back. They have done research for last 3 years on this and presented posters in national forums. And Riley is already teaching a course on medical marijuana, medical marijuana, you have the, right? So we have to create a psychedelic education and curriculum for medical students because
Education is key, right?
Key.
Take away the stigma.
because we teach few people, but our student rotate with 100 doctors in their career, right? So they are our brand ambassadors, and through them we can basically create advocacy, right? Like it said that charity begins at home, right? Right? That our empathy and charitable activities should begin with our med school, our own home, our own temple of learning.
So I think we have maybe a final question up here in front of the auditorium, and then after that we will move our way out of the auditorium. We have a bit of a reception, food and drinks and everything, and we can continue the discussion.
Hi, I hope everyone doesn't mind me introducing myself a little bit. First of all, thank you to the panelists, to Riley, and everyone at Cooper for creating this safe educational space. My name is Catherine Halley. I'm a 21-year-old cannabis technician or bud tender, whatever terminology you want to use for it. But also in February, I just graduated with my Bachelor's of Science in Biology, and I did my thesis research on the benefits of psychedelics for neurodegenerative diseases. So I'd love to talk more to Dr. Bottom
Sure.
about your experience with Parkinson's patients. But I think your question perfectly helped me lead into this question. But I'm in the process of applying to master's programs. Specifically, the University of Wisconsin now has the psychoactive pharmaceutical investigation master's program. So I'm in the process of applying to that, and all the scholarships that go along with it. But I guess my question is, how would you recommend someone like me, as a woman, how would you recommend me jumping through all these hoops, especially in an industry where a lot of people start off in unorthodox ways? Some people first become plant patients before they get into this as a career. So does anyone have any recommendations for me?
No, thank you for asking. That's very humbling, and congratulations on choosing. Yeah, congratulations on choosing your journey in Wisconsin. That's the place of first MRI, functional MRI study for effect of mindfulness meditation by Richie Davidson. So that's a great place. But my personal advice is I wanted to be a monk because I wanted to have the lived experience of meditation. And my teacher say, the monk's teacher say, before 8 years into regular practice of meditation, don't even tell anybody that you meditate. Because he say, meditation is like a small sapling, like a plant. And the plant is vulnerable to be trampled by many buffaloes and cows, which are rampant in India. In any street of India, there are buffaloes and cows. He say you have to protect the sapling. And the protection is by not telling anybody. First, perfect your practice, have the lived experience, then apply that for humanity. So based on my experience on meditation and neuroscience, I will recommend you follow the same. That you first have some lived experience of it, and then read the books, and test whether the books are right or wrong, whether they fit to your lived experience, and if they don't fit, what is the gap, and find a mentor or mentors who can bridge the gap. So that will be my humble suggestion.
I'll add to that just a little bit. So if you go to University of Wisconsin, we Revitalist and Wake, we actually have interns there from the program that you're applying to. And we're getting ready to start a deprescribing protocol with functional mushrooms and ketamine and psilocybin. So it'd be a really neat internship. But then also too, so in anesthesia, the last I checked, the rate of addiction for anesthesia providers is about 30%. We have the highest rate of addiction of any medical provider out there. So I completely avoided everything just because I have a binge-like personality anyway. So I watched and observed and did everything else first, and then I go down to the retreats with Wake down in Jamaica. I'm one of the providers there, and I stay in the background. I let Sita do everything because I'm way too American, she tells me. So I just sit back if there's other issues that have to be addressed. But my personal opinion, I watched it. I went to 4 retreats. I didn't trust anything. As an anesthesia provider, he knows we get very granular with dosing, and we're very much control freaks. So, for me to be in the middle of the woods seeing all these other people, I was like, I just don't know. I just don't know if I could do this, right? So, so I finally did it, but it was a step out of bravery per se, and also turning my back on this industry to where it's like, am I going to get addicted? Am I going to do this? Am I going to lose control, right? So, he was saying, it's analyze it, see what you want to do, or don't. And you're going to find those polarizing views in medicine everywhere. I mean, your entire life, you're going to find people who just know this is a fact, and this side knows this is a fact. So always take the next path, don't stop.
I'll add one more thing if I can quickly. One other thing I'd suggest is network. It's something I speak to students a lot about, and it's actually been really beneficial for me, and it's probably opened up most of my careers, my board opportunities, getting involved in different things, and you just find yourself in the community in which you want to learn and grow. So 4 years ago when I kind of started this journey into this space, that's exactly what I did. I would take off work from my day job and go to a conference that I would pay for, just so I can go, learn, hear from experts, meet the experts. And when you do that, it just creates opportunities. I mean, just being around people in the space, sharing that you're interested, sharing your passion, and sharing what your experience and background is, there's a place for you. You just have to kind of keep following that, and it will open up.
That's a perfect segue, Jessica, into networking, because we should now network and leave the room and network. And also, if going forward, I went the graduate school route. I did my PhD in neuroscience, and there's lots of different ways you can interface with the topic of interest. You don't necessarily need to become a professor. You can become a caregiver. There's legal aspects, policy aspects, intellectual property aspects, lots of different ways to follow your interests. But the key to that is networking, to understand what you want to do, which aspect you want to approach. And we have a lot of diversity of knowledge and opinion here, which I'd like to thank everyone for participating in the panel, especially Riley. Thank you so much, Riley, for enabling this event and for sharing the documentary with us. So let's go grab something to eat.